Good morning, everyone. Thank you for joining us for the second session as part of the Education Day. I'm very honored and wanted to thank the organizers to make a specific session about diffuse midline glioma. And so I'm going to give the introduction and broad overview of the disease and then outline some of the therapies we are working on. And then we have two wonderful speakers, Jasper and Sriram, who will then walk us through some metabolic targeting agents as well as immunotherapy. So let's get started. These are my disclosures. So I'm a professor of pediatrics, neurology and neurosurgery at UCSF and also at the University of Zurich in Switzerland. So to give an overview of the disease, so diffuse intrinsic pontine glioma, DIPG, they account for about 75 to 80% of all brainstem tumors in children. And survival remains very poor despite really exciting developments that we are learning as a community in understanding the biology and also introducing new therapies. Historically, as many of you know, DIPGs were diagnosed based on imaging and within the right clinical context. So most commonly presenting symptoms of DIPG are a triad of clinical signs that include ataxia, cranial nerve dysfunction, as well as lung tract signs. And there is a differential diagnosis we need to consider when we see brainstem lesions, and these include either low-grade lesions, embryonal tumors, or also demyelinating disorders. And in 2012, there was a big breakthrough where two independent groups discovered the disease-identifying mutation in the H3K27M, leading to global reduction in the trimethylation mark of the histones. However, there's really evolving pathological criteria to diagnose diffuse midline glioma. Initially, this mutation was discovered really in the pontine setting, but we now understand that a lot of these midline tumors also occurring in the thalamus, midbrain, or in the spinal cord also carry the H3 mutation. And that led in 2016 to a new entity that was called diffuse midline glioma H3K27M mutant. And there are different working groups, and I think one of the key hallmarks that we need to make sure we have when we diagnose these tumors is really this is a diffuse infiltrating tumor. And then in 2021, the WHO classification was updated to include diffuse midline glioma H3K27 altered, accounting for diffuse midline gliomas lacking the H3 mutation, but still showing the global loss of trimethylation immunostaining. And one of the ways how that is possible is through EZIP overexpression. Then several groups have looked at clinical predictors of outcome in DIPGs. Several US and European-based studies have shown that age less than 3 years of age and 10 years are associated with improved outcome, that longer symptom duration is associated with prolonged survival. For the more aggressive types, we sometimes only have a history of 2 or 3 weeks. Ring enhancement at time of diagnosis appears to be a negative predictor. And then there's really controversy in the literature regarding whether tumor volume at initial diagnosis or after radiation therapy correlates with overall survival. What recent studies have shown from the University of Michigan is also how does really the socioeconomic impact clinical outcomes in DIPG, DMG. And I think this is a topic we need to address more globally in general for pediatric cancers. But basically, what this group was able to show, here you can see that there's a difference in terms of race and ethnicity, how far people travel for clinical trials, and also the trial enrollment rate. But then basically, if you look at how the household income impacted pediatric DMG, DIPG survival rates, this is pretty striking, showing that there's a significant difference in survival if you have a household earning less or more than $50,000 US. If this would be obviously a therapy we are developing, we would be very excited. So that's another way where we really need to tackle improved outcomes. Since we made this updated diagnosis where we are now including a variety of locations in our clinical trials and calling them diffuse midline glioma H3K27M altered, it is also important to understand is there a difference between adults and children and the location. And just to outline here, this is a study, one of the larger ones that has been published by the UCSF Adult Neuro-Oncology Group. They looked at 60 adult patients, and what they basically were able to show that adult patients have superior outcomes compared to children. Most of the adult tumors are located in the thalamus, less in the spine, and then in the brainstem. And the median overall survival, and these patients were treated with standard biopsy and radiation, and then often in the adult setting, these patients are still being treated with temozolomide, was 26.6 months. And I think what the field is struggling with is that mainly a different cell of origin. Is this purely because that adult patients present more often with thalamic tumors versus pontine tumors? And this is just showing a distribution that we frequently see. As mentioned, adults have many more tumors located in the thalamus versus other locations, whereas for pediatric tumors, we often really have a pontine location as a predominant location for these diffuse midline gliomas. So I think it's something we're still trying to understand, if it's basically just location, is it the tumor environment in these different locations that really predict outcome. The other key question, I think, that is handled quite different depending on the country and the center is really what is the frequency of dissemination in DIPG and DMG, and should spine MRI acquisition and CSF collection be standard of care for these children and young adults? So we know that these tumors can spread and that there can be evidence of disseminated disease. Leptomeningeal spread has been reported in as many of 20%, but the acquisition of spine MRI is highly variable, so maybe we are really underdiagnosing disseminated disease in these patients. CSF collection via lumbar puncture has been shown to be safe and feasible, so it's something that many centers are now establishing as routine testing for these tumors. And then also CSF collection offers potentially additional molecular testing of cell-free circulating tumor DNA for diagnostic purposes when a biopsy is really not safe to be performed. And then when we look, is it important to understand the molecular characteristic of DIPG DMGs? And I think the answer is clearly yes. We have shown that different alterations, different subgroups are associated with different outcomes. And here listed different studies from also the European group showing that the H3.1 mutations with ACVR1 alterations might have superior outcome compared to the H3.3, especially in the setting of P53 alterations. And then recently, just to give you a flavor, there are now new subtypes of diffuse midline glioma that are being discovered. For example, if these tumors have alterations also in the MAP kinase pathway, such as NF1 alterations, they seem to have better outcomes. So I do think that in order to understand any new therapy within the context, we really need to understand the molecular heterogeneity of your clinical trial cohort to really understand the impact of your new therapy. And then there are other co-alterations that might impact outcome. This is a study looking at ATRX loss and retention, and you see just stratifying by that marker, there are significant differences in terms of outcome. And so the key point is really to take home here that in order to develop new therapies, we really need to understand the molecular context of our patient population. And so the historical view here shown was diagnosed on imaging only, and I think that is still the case in many centers and in many countries. Dexamethasone is often initiated at the time of diagnosis and frequently continued during radiation therapy. But I think there is really a trend in different centers who take care of many of these patients to avoid the use of dexamethasone, given really the detrimental effects dexamethasone can have on these children with massive weight gain, steroid-induced myopathy, often sleep disturbance, behavioral changes. So we are really trying to move away from dexamethasone. Sometimes centers now use more bevacizumab to control potentially radiation-induced edema. Radiation therapy still remains the cornerstone of treatment. Focal standard fractionation remains the standard of care. And then in the US, and I think that differs with, for example, the standard of care in Europe, we don't use or recommend temozolomide with radiation therapy. And then I think for all centers, given that we really lack a good standard of care, clinical trial enrollment is really preferred due to the absence of established standard of care. And then when we look a little bit closer, there are now different practices what type of radiation therapy is being employed for these tumors. So these are contemporary studies showing that the standard radiation therapy, the median overall survival for these tumors is about 11 months. We know that without radiation therapy, the median survival for these patients is about 4 months. And prior studies looking at if increasing the dose of radiation therapy, is that really improving outcome? That really has not been shown to be true. So we are not pursuing that strategies anymore. But what is currently being pursued, because the standard radiation therapy really commits these children and young adults to 30 fractions over 6 weeks. Often these children are less than 10 years of age. They often require daily anesthesia with the radiation therapy. And so different groups have investigated the role of hypofractionation as a preferred radiation therapy strategy. And this really would lead to reduced patients' burden because you have a shorter time of radiation therapy, and it would require less anesthesia, less travel, etc. In some of the centers now, this is really offered as part of standard of care, and there are different regimens or different studies showing that overall the outcome using the standard regimen of 54 gray over 30 fractions versus 39 gray, the hypofractionation course over 13 fractions, seems to be equivalent. There are also larger studies who looked at this. This is one of a study from Egypt, randomizing 253 children with newly diagnosed DIPG, but based on imaging only. And they included different regimens with 39 gray versus 45 gray and compared those to the standard fractionation of 30 fractions, total of 54 gray. And basically, median overall survival was comparable in the different groups, as shown here. So these are some of the things that different centers are currently exploring for the treatment of children with these diffuse midline glioma. But when we are thinking about what can we offer to our patients after completion of radiation therapy, really the key challenges we face developing new therapies is really we have a very small patient population, and especially when we take into account different subtypes, as I mentioned previously. We have limited access to treatment tumor samples given the eloquent location. So many of us now really favor and consider standard of care to perform a biopsy at time of initial diagnosis, but we rarely take another biopsy when patients fail or at time of progression or during treatment. So we really have a very limited understanding what happens to these tumor cells, what are changes we encounter due to the therapy we are employing. And one of the key challenges that I will address also in sort of the subsequent part of my talk is really the blood-brain barrier, which limits significantly drug exposure and decreases the therapeutic index. Many of the agents we can test in clinical trials for our children and young adults with diffuse midline gliomas are actually designed by pharmaceutical companies specifically not to cross the blood-brain barrier to avoid basically cognitive side effects. So this remains an issue for us. And then obviously we are dealing with a very small patient population, and so there's limited interest from industry to invest in the development of new therapy developments for the specific patient population. But then what are the current strategies we are trying to test as part of different consortia-wide efforts or single institution efforts to improve the outcome for these children and young adults with diffuse midline glioma? So one is really how can we better get our medicines or drugs through the blood-brain barrier? So I will discuss a little bit convection-enhanced delivery as well as focused ultrasound. There are several new immunotherapy approaches that will be discussed by Jasper. We have metabolic targeting agents that will be addressed by Sriram Venneti. And then there's this whole new, very exciting field of glioma neuronal inhibition. We learned from wonderful work by Michel Mongi that there's direct connection between the glioma cells and the neurons, and how can we potentially harness these interactions and crosstalk that seem to be really needed to maintain sort of tumor growth for therapeutic intent. And there are certain efforts now being underway looking at specific anti-epileptic agents, but we will not have time to discuss that in detail, but it's a fascinating topic. So how can we overcome the blood-brain barrier and increase the therapeutic index? So one of the areas that have been heavily invested by several investigators in the US, but also in Europe, is really the use of convection-enhanced delivery. And so we have worked with Chris Benkovitz at UCSF, who really, and I'm summarizing here 10 to 15 years of work, using with canine patients. So these are dogs, they are not models, so these dogs develop gliomas which appear very similar than the adult tumors, and basically worked with the veterinary school to define even just the catheter placement. And I'm not sure if this video will work, but what we have been able to show is if you refine the catheter and do a step catheter, that you can really avoid reflux along the catheter site. And that really took several years to accomplish, but then this is now being moved into the clinical area. And so here's just outlining again what is really the key issues, why we see limited brain tumor therapies being successfully translated, and one of those is really the limited tumor penetration. And so, sorry, here's some mix-up. So this was the video I wanted to show. So on the right-hand side, I don't know if you can see increasing of the white area along the trachea, and this is basically co-infusion of chemotherapy agent within gadolinium, so that we can track directly sort of the infusate after convection-enhanced delivery. And so when we tested this initially in dogs, many of them but few of them were able to survive and really responded well to this treatment. And so we tested one of the agents that had showed very great success in the preclinical setting, which was HDAC inhibitor panobinostat. And we worked with a company who made a soluble version of this, which is called MTX110. And so this is in rat models showing that we were able to prolong life in these rat models of diffuse midline glioma, and that we saw a nice increase in the concentration of MTX110. And so what we put forward at UCSF as part of our PNOC trials was, in collaboration with Nalan Gupta, Chief of Pediatric Neurosurgery, we implanted each time a child would come to the clinic and receive a new procedure. We placed this tiny catheter directly into the brainstem, and then these children would come back every 4 to 6 weeks, depending on their recovery. And so this was PNOC 15 that has recently been published. And so these children enrolled 4 to 14 weeks after completion of radiation therapy, and then received as much as tolerated every 4 to 6 weeks these infusion. And we employed an accelerated dose escalation design. We enrolled a total of 7 subjects with these mutant DIPGs with a median age of 8 years. And overall, I would say that the treatment was pretty well tolerated. We first escalated the amount of CED infusate, which you can see from 3 cc's to 6 cc's to 8 and so on. And then we went from day 1 to day 2 infusions. And then in a subsequent step, we also increased the concentration of the MTX110 solution. And so over time, we were able to increase, obviously, the tumor coverage given repeated infusion of MTX110 directly into the brainstem. But as you can see on the left-hand side, our tumor coverage aggregate ranged from 35% to the highest about 78%. And obviously for a more standard-based chemotherapy, that is not sufficient. So I think this is a very good therapy to consider to achieve local control, but it needs to be combined with something so that we can look already at the disseminated disease that is most likely present beyond the pons when we employ these more local strategies. And this is just one example. Here, again, you can see that there was a transcerebellar approach where we placed the catheter we infused the MTX-110 with gadolinium, and over time, we basically were able to cover it. What was encouraging, despite that we discontinued the trial after only 7 patients, was the overall survival. But please really take this into consideration that this was a very small sample size, but the median overall survival was 26 months. And at this time, the company made the decision that we will discontinue this phase 1 trial and wanted to move to a multi-institutional phase 2 study. But of course, as always, money is an issue, and we are waiting for some of the adult data. So, but I am looking forward to continue this line of work. What we also try to establish as part of this trial, can we use circulating tumor DNA for response assessment? And this is really work I'm collaborating in with Karl Koschmann and his team, because often when we employ new therapeutic strategies for these diffuse midline gliomas, we are losing a little bit our imaging assessment, especially in the setting of immunotherapies or direct infiltration of chemotherapy agents in the pons. These can also cause flare changes that we often use to determine overall tumor volume. And so we were looking, can we determine, specifically looking at the H3 mutation and the amount we detect either in the cerebral spinal fluid or in the plasma as a response marker. I think there are some patients for that it's feasible, nicely published here as well, but I would say in our experience, it's still highly variable and something we need to refine. And we have been able to look here only at plasma, and in the next iteration of trials, I think looking at CSF will be much more precise, and I think will help us to determine an alternative method to look at responses or failure earlier on compared to just standard MR imaging. And just in the last few minutes, another area we are heavily investigating, again, looking at how can we improve the blood-brain barrier penetration of our agents, is a field that has received a lot of attention recently in the DIPG field, is really the use of focused ultrasound. And how that works is basically patients are being injected with microbubbles, and then you focus the focused ultrasound beam in the area where you want to open up the blood-brain barrier. And then through the focused low-intensity ultrasound, you start to oscillate these microbubbles, and then that sort of disrupts the tight junction, leading sort of to a temporary breakdown of a blood-brain barrier that then closes. And the time frame, when you look at the published literature, it's about 6 to 24 hours, but you have a peak where the blood-brain barrier is open. Ideally, during this time, you infuse your agent of choice, and then at the end, it closes again. And so there are now different types of focused ultrasound platforms that are being employed. We have the InsightTech device, the Calthera, which is an implantable system that is especially put already in use in children in France, I believe. So there are many different technologies that we can now use to potentially also harness focused ultrasound to increase the blood-brain barrier penetration. And so just going back to panobinostat, this was one of the studies recently published in Advances in Neuro-Oncology, showing again that by using also focused ultrasound delivery of panobinostat leads to improved outcome for models of diffuse midline glioma. And now this is already in clinical trials in the US. So there's one study led by Fred View from Columbia. They have their own sort of homemade device where the patients are basically sitting in clinic, getting the blood-brain barrier open to this device you can see here, and also in combination with panobinostat. There are other studies underway. This is from Dennis van Buren from the Princess Maxima Center, where he's using also the InsightTech device to use it in combination with temozolomide, and we are excited to learn about the results of the studies. And then there are a few other trials that are being open now in the US, looking at etoposide as well as also doxorubicin at Children's National and at Columbia University. The area we are pursuing also within our consortium, PNOC, is also that several studies have shown that focused ultrasound with microbubbles also have immunomodulatory effects, and how can we harness that potential combination of focused ultrasound with other immunotherapy targeting agents. And this is something we are currently exploring and developing. So there's also nice data showing in Alzheimer's disease that the opening can basically alter sort of the microenvironment of the area. And so we spend a lot of time thinking about how do you best design these studies, because one area is obviously how much of the tumor are you subjecting to opening up the focused ultrasound, and are there any negative side effects? There's some concern, for example, could this lead to hemorrhage? And then obviously as you increase your agent, how do you best deal with that? And sort of one of the potential concepts we have developed is basically that you're using the recommended phase 2 dose, but start with 50% of the tumor to be basically subjected to opening up of a focused ultrasound, and then you increase over time within one patient over different cycles. So it's just, when you think about the development of these new combination strategies, you have sort of a device and a delivery part, and you have your agent of choice. I think it's interesting to see, and how can we best learn as a field how we escalate this within one patient, so that one patient obviously derives the most benefit from any given therapy. And then the other area, which I will just quickly highlight before I will come to a close, is there's also a lot of preclinical data showing, especially based on the location of these tumors directly in the brainstem, can you also use something like intranasal delivery of agents for the treatment for these pontine tumors? And that's something we are going to move forward as well. And then just to briefly highlight sort of key initiatives for diffuse midline gliomas, there are several larger consortium studies. This is a platform umbrella trial from the CONNECT consortium, where basically patients with diffuse midline glioma and specific alterations are being assigned specific therapies, mainly really after completion of radiation therapy and sometimes with combination of radiation therapy, really getting to the point that most likely one therapy will not work for all different subtypes we see in DMGs. We have a large BioMedi trial in Europe. We had BioMedi 1.0 looking at the combination of everolimus, dasatinib, and alatinib, also in a biomarker randomized study. And this work has been presented by Jagril. And now the ongoing BioMedi 2, which is a randomized study looking at ONC201 and then everolimus. In PNOC, we are currently looking at ONC201 and paxelisib plus a novel agent, again based on preclinical studies, where children can participate when they are newly diagnosed, post-radiation, or also at time of recurrent disease, which was a big ask from our foundation and families, that children at time of progression will also have an opportunity. And this is just one of the first designs where we are collecting also CSF, tumor tissue, as well as the microbiome. And so with that, I will end. I hope this was a nice overview of the disease, as well as some of the therapeutic intents we want to achieve to open up the BBB. And with that, I want to acknowledge, obviously, all my wonderful collaborators and different teams, as well as our supporters. And then, obviously, with gratitude to our patients and families. Without them, we couldn't obviously complete any of this work. And thank you for your attention. We had discussed that if there are any questions right now, we will have them after each talk. So if there are any questions.
So Dr. Vic from India. This is probably a very, very kind of basic and stupid question. But I was interested in the sequencing. In all of them, you're doing radiation first, and then opening up the blood-brain barrier and giving chemotherapy later on, or whatever agent you pick. But is there any study which is doing neoadjuvant treatment using focused ultrasound?
Before radiation therapy?
Right.
I think it's a great question, and I think we know that there are certain diffuse midline gliomas who really don't respond to radiation therapy, and we are actually currently working on a large collaboration identifying that signature, and I think these patients would be much better served to start with another therapy up front rather than radiation therapy. I think it's not quite where the field is. I think the majority of us still considers radiation as a first step, but I fully agree with you. And what we also don't understand, does radiation therapy change these tumors in a way that some of these will not be as effective? Great question, and I hope in the future we will have patients who will not undergo radiation as a first step.
Thank you. Sushi Manabe from Japan. I'm quite impressed with the talk, especially blood-brain barrier and CSF cytology or CSF DNA measurements. So you're currently doing these CSF measurements to actually to use that for monitoring the disease or not yet?
If you're using CSF to monitor the disease, we are doing it as part of a clinical trials and are still trying to develop sort of methods. There's either looking just at using digital droplet PCR, just looking at the H3 mutation and the abundance of those, and is that predictive of response or not. We are also working on whole genome sequencing and see if that would help us also to understand potential changes we see with therapy. But we haven't, I think we are starting to accept CSF results also for diagnosis, but I don't think we are quite there yet.
Okay.
Yeah.
So then the next, sorry, but the last. So this is in Hawaii. We are now in Hawaii. I'm from Japan. So your consortium is quite attractive, but you will, I don't know, recruit studies outside USA or Europe.
Yeah, no, I think it's definitely our intent to bring our studies more internationally. I think we really need to work globally to make faster progress. Yeah.
Okay,
thank you very much. So I think with that, we will move on. So it's really my honor and pleasure to introduce Sriram Venneti. He's professor of neuropathology at the University of Michigan. He's co-leading also the Pediatric Brain Center there and has done really fantastic work in looking at metabolic targets for diffuse midline glioma. Thank you very much.
Thank you, Sabine. That was such a phenomenal talk and overview of DIPG and some of the cutting-edge work that's being addressed in forms of clinical trials. So I'm going to be talking about metabolic therapies for DMGs. As Sabine said, I'm from the University of Michigan. We have this amazing DIPG center there called the Chatkar Pediatric Brain Tumor Center, and I wanted to present some of the work that was done in collaboration with PNONC and others. I have no disclosures. So the outline of my talk is as follows. So Sabine talked about diffuse midline gliomas as having this pivotal mutation, H3K27M, and it's viewed as an epigenetic disease. So I'm going to go into a little more detail about what the mutation actually does. And then the focus of my talk is basically on cancer metabolism. So how does the mutation change metabolic pathways in tumor cells, and can we actually target this for drug development? So I've divided my talk into two parts. The first part is, can the mutation itself drive these integrated epigenetic and metabolic pathways? And two, can we actually target this using this drug, that ONC201 that Sabine just talked about? And then finally summarize it. So as Sabine mentioned, these were the two key papers in 2012 that discovered the cystone mutation from Nader Dabaru's group and Susie Baker's group that were published. And majority of the mutations are seen in this gene, H3.3, with rare tumors having this 3.1 mutation that Sabine also said. Both these mutations happen in the lysine at the 27th position. This is mutated to a methionine. So this is in histone H3. So to understand this, I'm going to attempt to give a very bird's eye overview of what this mark means and what this mutation means. So we have vast amounts of DNA in our nuclei, and these all have to be compacted into really tiny spaces. So one of nature's marvels is to take this DNA and roll it around histones, just like you're spooling wool, and then you compact this within the cells. But then this creates a problem. If you have all the DNA compacted, how do you access genes? How do you turn on genes and turn off genes? So it's a very clever system in which you can shift the DNA from a closed, compact state to a more open state. And this is actually done by many mechanisms, but one of the mechanisms is that these histone proteins have tails. And then you can add post-translational modifications to these tails that enable compacting the chromatin or opening it up. And one of these marks is the K27, H3K27. This is a trimethyl mark. 3 methyl marks are added to this tail. And this is associated with compacting the chromatin. So you close the chromatin. And so genes are not expressed. But when you want to open up this chromatin, you remove this mark. Then now you can add another mark, the 27 acetyl. So you acetylate the tail at this region. And along with other histone modifications, you can open the chromatin. And now the RNA polymerase can come and actually transcribe genes. So it's a very clever system of closing the chromatin and opening the chromatin. And this mark is very critical to the closed chromatin. So because it's such an elegant system, you would think that the mechanisms that actually mediate these are also very elegant. There are specific writers that add this mark. There are erasers that remove this mark. And this mark can be read for the genes to be transcribed. So it's a very specific system. The mark the writer that adds this mark belongs to the PRC2 complex. This is the polycomb repressive complex 2. And the main enzyme, the methyl transferase that transfers the trimethyl, is EZH2. The eraser is this lysine demethylase. K stands for lysine, DM for demethylase. And the two specific enzymes here are KDM6A and 6B. So what happens in the histone mutation? When this K is mutated to an M, it inhibits the function of the writer. So the pencil is not able to put the trimethyl mark again. The function of the pencil is inhibited. However, the eraser still works. And so people have shown that in this situation, this EZH2 function is actually inhibited. So what does this actually do? I also wanted to mention that you can inhibit this eraser in these mutations to actually increase this 27 trimethyl mark, and I'll come back to that in a bit. But what does this mutation do? So if the writer function is not happening, this mark is not placed. So this is an immunohistochemistry for this mark. And if you look in the H3 wild type, this is immunohistochemical staining. All the brown are tumor cells, so you can see all the tumor cells retain this mark. When you mutate this, you get a loss of the 27 trimethyl. You can see blue where the brown is actually absent from the cells. This stain did work because you see internal control endothelial cells and immune cells that retain this mark. So this is a defining feature of these tumors, this loss of 27 trimethyl that also Sabine talked about. So because the mutation is in this key epigenetic factor, it's viewed as an epigenetic disease. So we sought to see if there are other pathogenic mechanisms that actually drove this tumor. And so we sought to cancer metabolism, and this was because metabolic programs are a hallmark of cancer. And this is described very well in this beautiful book. This is Otto Warburg. This is the Warburg effect. And Warburg thought this was a passive process. We now know this is not a passive process. This is actually an active process where mutations will take metabolic pathways and actively change them. So on top is a resting cell, and on the bottom is a proliferating cell. And in cancers, the proliferating cell require nutrients to support this uncontrolled proliferation. So what they'll do is they'll take up vast amounts of nutrients such as glucose, amino acids, and lipids. We use this every day in the clinic as FDG PET, which is a form of glucose that is taken up by these cancer cells. And we know that this is an active process. So we sought to see if this mutation, this histone mutation, can actually change this metabolic pathways. We are also interested in this because metabolic pathways speak directly with chromatin modifications, and I'll show you an example of this. So in this complicated slide that we have all repressed from biochemistry, glucose is converted to pyruvate through glycolysis. Pyruvate then enters the TCA cycle and is metabolized in the TCA cycle. One metabolite here, alpha-ketoglutarate shown in blue, is really critical because what this alpha-ketoglutarate does is it's really important for this eraser to work, to erase this mark. So alpha-KG is a critical cofactor for these lysine demethylases. So without this cofactor, you will not have the demethylase reaction. So this is a way in which the TCA cycle can talk directly to the epigenetic chromatin machinery. So given this premise, we hypothesized that H3K27M mutation drives these integrated metabolic and epigenetic pathways. So a series of experiments, we landed on this enzyme called isocitrate dehydrogenase 1. I'm showing you where IDH is sitting in the TCA cycle. Its main function is to convert isocitrate to alpha-ketoglutarate. There are several isoforms. The two main isoforms are IDH1, which sits in the cytoplasm, and IDH2, which sits in the mitochondria. And you can see here that it's IDH1 that's higher. In red are the three K27M mutant cell lines. In blue are the wild-type cell lines, and you can see IDH1 is higher in the K27M as compared to the wild-type cell lines. If this were true, then the metabolite produced by this enzyme should also increase, and the metabolite is alpha-ketoglutarate. So in this graph, we're plotting the fold difference in metabolite between K27M and wild-type cells. And you can see in blue is alpha-ketoglutarate and the TCA cycle metabolite. It's really high, suggesting that this enzyme is doing what it's supposed to do. So just to remind you, this eraser is really important. And if you inhibit the eraser, previous work from others have shown that this 27-trimethyl mark goes up and kills these mutant cell lines. So if IDH1 was creating this metabolite, alpha-ketoglutarate, and an alpha-ketoglutarate was required for this demethylation reactions, what happens if you inhibit it? The hypothesis would be that if you inhibit IDH1, then this metabolite, which acts as a substrate for the eraser, shouldn't work, and then you should get higher trimethylation. So this is the hypothesis. So we set out to test this. So we used siRNAs and shRNAs, and you can see these are blots in K27M cells where we used siRNAs or shRNAs to knock down IDH1, and you can see there's a good knockdown by Western blot. And the expectation is this 27-trimethyl mark will go up, and this is what we see. And the red boxes are a Western blot for this 27-trimethyl. You can see that either with Si or with shRNAs, you can see an increase in this mark. This causes the cells to crash. Here we're plotting the proliferation of these cells over time in 5 days. And then the blue and the maroon line are controlled cells, and the other two lines are cells with the shIDH1. And you can see that the cells crash and don't proliferate. So the take-home part from this is that normally, these K27M mutations drive through IDH1 alpha-ketoglutarate production, and this maintains this low 27-trimethylation. And if you inhibit IDH1, you can actually increase this 27-trimethylation. So this study was really interesting to us to suggest that the epigenetic and metabolic pathways talk to each other in these mutant tumors. However, the IDH1 inhibitor is just a tool compound. So we were searching for a drug with the hypothesis that drugs that alter TCA cycle metabolism and alpha-KG levels will be therapeutic by impacting 27-trimethyl, and by impacting, I mean maybe reverse the 27-trimethylation. And the one drug that we landed on was this drug that Sabine referred to. It's ONC201. It's an imipridone. It has several mechanisms of actions, but one of its mechanism of action is to activate this mitochondrial protease. So protease is an enzyme that chews proteins up, and this normally should be inactive in our mitochondria. But what happens when you treat the cells with this drug is you get aberrant activation of this protein, and it starts chewing up mitochondrial proteins. So this was a phenomenal clinical trial conducted by PNONG, led by Carl Koshman, Sabine, and Javad Nazarian. And this is recent data from a paper. Here is a patient who was treated by this ONC201, and you can see at baseline compared to almost 400 days after treatment, you can see a reduction in the size of the tumor. This is the clinical trial. From this, there are two trials here, ONC201 14 and 18, and the orange line represents the total. You'll notice that there is no untreated control here because the study was not designed. But here, what's important is the median survival is 21.7 months. And as Sabine has just said, just with radiation treatment, the median survival is between 9 and 12 months. So this did show promise in a subset of patients. So to delve more into this, what we did is we took responders and non-responders, and we looked at baseline genes that were different between the responders and non-responders. And we did this by RNA sequencing of the brain tumors itself. So what we found is that, highlighted in black and in red here, is that patients with higher mitochondrial metabolism with oxidative phosphorylation and higher TCA cycle metabolism seem to respond better. So this led us to the hypothesis that maybe this drug is changing the TCA cycle and maybe changing this integrated metabolic and epigenetic pathway. And when we did a series of studies in vitro and multiple cell lines, we found that the top pathway downregulated is the TCA cycle when you treat cells with this drug. So I'm cutting a lot of data short, but one of the key proteins that's reduced by this drug is this gene called OGDH. So this gene, OGDH, takes alpha-KG and degrades it. So it removes it within the TCA cycle. And you can see when you treat with this drug in 3 independent DIPG cell lines, you get a reduction in this protein because this drug is activating the protease that chews up this protein. So if you find that this protein is being chewed up, you should get a backup of alpha-ketoglutarate, and that's what you see. So the alpha-ketoglutarate levels actually go up when you treat these cells with ONC201. What we unexpectedly found is that this alpha-ketoglutarate was being converted to this metabolite called 2-hydroxyglutarate. So what is this? Before that, I wanted to show you examples from this trial of 2 patients. This is an ONC201 responsive patient. You can see with the MRI scans there's a reduction in the tumor volume. The tumor area is plotted in purple here, and you can see the tumor volume is going down with treatment. The CSF levels of 2-HG is plotted in red, and you can see that it's going up on treatment. Here is an ONC201 resistant patient. You can see the baseline and after treatment. This tumor in the thalamus doesn't change in size. This patient also developed a metastasis in the cerebellum. In the same graph, in red is the 2-HG levels. You can see it drop, and the tumor volume in blue doesn't seem to change. And here is from a small cohort of patients that we have now confirmed in a larger cohort of patients between responders and non-responders, the CSF levels of this 2-HG go up. So what is 2-HG? So here is the structure of alpha-ketoglutarate, and here is the structure of 2-HG. You can see that they only differ in this hydroxyl group. So 2-HG is very structurally similar to alpha-KG. So what it can do is it can inhibit alpha-KG functions. 2-HG comes in 2 flavors, the D isoform, which is seen in IDH mutant tumors that I'm not going to talk about, and the L isoform. So what we detected is that the L isoform was being made in these tumors, and because of its structural similarity to alpha-KG, it can inhibit this eraser and cause this increase in trimethylation. Here is data to show you that it is indeed the L2HG form that's being made. Here are 3 K27M cells. We're plotting the L2HG here on the y-axis. The blue are vehicle-treated cells. The red is ONC201 treated cells, and you can see that the L2HG levels go up on treatment. So because L2HG competitively inhibits this eraser, we expect that ONC201 would increase L2HG, and this would increase 27-trimethylation. And just to remind you, this low 27-trimethyl is a diagnostic preferred epigenetic state of the cells. So we just added L2HG to the cells, and then you can see here, when you blot for 27-trimethyl, it goes up in the cells. So the hypothesis holds good, where if you treat cells with ONC201, here are 5 independent mutant K27M mutant cell lines, you could see that in a dose-dependent manner, you get an increase in the 27-trimethyl. More importantly, we saw this in patients. Here is a patient pre-ONC201 treatment. We're doing immunohistochemistry for 27-trimethyl, and you can see a global reduction in tumor cells, as I showed you before. Here's the patient biopsied on trial, and you can see the 27-trimethyl mark goes up, reversing this diagnostic criteria for these tumors. Here's the quantification. The black bars are wild type, H3 wild type with high 27-trimethyl. The blue lines are untreated K27M or non-ONC201 treated. You can see there's really low levels of the 27-trimethyl. And when you treat with ONC201, this is reversed. This also leads to changes in the epigenome itself. So here I'm showing you chromatin accessibility. To just remind you, this mark is really important for closing the chromatin or opening the chromatin. And you can see that in some regions, at promoter regions, when you treat with ONC201, consistent with the change that's happening, the chromatin accessibility actually drops. And I'm showing you the tracks, chromatin accessibility tracks for a gene called nestin, which is a glioma stem cell marker. So the stem cell signature is going down. When you look at all the genes that are being affected, majority of the genes seem to land on cell cycle-related pathways and differentiation pathways. So suggesting that this drug, through this epigenetic effect, is suppressing cell cycle and is causing the cells to differentiate more. And in this work, in vitro is also confirmed by both Sabine and Javad Nazarian's group. When you treat these cells with ONC201 in vitro, the differentiation state of the cells moves. So I'd like to summarize the 4 key take-home messages that I'd like to convey to you. The first is that this K27M mutation, that is the defining feature of these tumors, leads to a global reduction in this 27-trimethyl mark, as seen here in a K27M versus H3 wild-type cell line. This K27M mutation consistent with cancer metabolism, as it's an oncogene, can independently change metabolic pathways. And the one pathway I'm showing you here is that it upregulates enzymes that result in production of this alpha-ketoglutarate, a TCA cycle-related enzyme. This metabolite, alpha-ketoglutarate, is really important for the eraser to act. So what this mutation does is it creates more of this metabolite to keep erasing the mark in tumor cells. ULTRA-201, this drug, produces this metabolite called L2-HG that is structurally very similar to alpha-KG and therefore can block the effects of alpha-KG in driving this eraser. So when you block the eraser, you see an increase in 27-trimethyl mark, as I showed you in these patient samples. So it's basically reversing the 27-trimethyl for the tumor to now resemble more of a wild-type tumor. So while this is early days, there's a lot of work to do, and certainly the drug seems to respond in about 1/3 of the patients. So there's many questions as to why is it not responding in the rest of the patients. What does this mark changing actually mean? Is it just pushing in a differentiation state? Is that sufficient? There's so many questions, and I think a key question is patients on this drug will always relapse. So what's happening in the relapsed tumor? So there's several questions to ask, and also another question is what does this drug do to the immune system? So I think with that, I'd like to acknowledge the wonderful people who did all this work. These are talented postdocs and graduate students from my laboratory. I'd like to thank my funding sources, and I would really like to thank leadership from PNOC, Sabine, Javad, and Carl, and all the collaborators on this study who enabled this work. So thank you so much, and I'd love to take some questions now. Thank you. So I know this is kind of like nerdy metabolism and epigenetics, so stuff that we've suppressed, it probably leads to PTSD for a lot of us. So.
Hi, Jaroslav Sterba, Brno, Czech Republic. Question to pathologist. Having in mind that the tumor microenvironment, metabolism, immune system is dynamic, highly interconnected system. Can you comment what was the development of tumor microenvironment, patients responding and failing on ONC201?
Yeah, it's a very good question. So my other job is I'm a neuropathologist, so I think we think about this a lot. So how the immune microenvironment changes in response to this drug in responders and non-responders is a key question. We're just starting to address these questions. So we have autopsy samples banked for patients who have been treated and non-treated, and we're just starting to delve into this. We're also looking at what this drug does to the immune microenvironment itself. Marta Alonso is in the audience. Her lab has led many of these studies. So it's a really important question, but we don't have the data to answer this question. Thank you. All right, we go to the more interesting part now on the immune therapy. So that's Jasper. And Sabine, will you be introducing us? Thank you, Lisa.
Yeah, thank you. And as last speaker of the session, we have Jasper van der Lugt, who leads the phase 1 program at the Prinses Maxima Center in Utrecht, Netherlands. And he will discuss some of the immunotherapeutic options for children and young adults with diffuse midline glioma.
Thank you very much, Sabine, and thank you very much to the organizing committee to give this talk. And I put in brackets and the challenges besides the options for DMGs, because the challenges are many, and I just try to touch upon some of those challenges along the way, but also some developments that has been made so far. I will talk about Jasper's environment, and being me, I live in the Netherlands, and the Netherlands is one of the most populated countries in the world, actually. But we also have quite the windmills, and then you start, because it's very flat, you start cycling. That's what we do in the Netherlands. But now I'm in Hawaii, and obviously that's me on the surfboard there. And you see your behavior start to change once you're in a different environment. And I think that not only holds true for people, but maybe also on a smaller scale. And I come back to that later on in the talk. So this has been discussed by Sabine, that DMGs are a lethal disease and they are influenced, the survival, how long you survive is influenced by where it's located and also the genetic makeup, but overall it's pretty poor. And we should not forget that behind all those graphs are children, individuals, and this beautiful boy who passed away already years ago did a nail polish action and raised $1 million, but not for DMG, but for female rights in Africa. So there's every story behind all those graphs. And therefore, sometimes being a neuro-oncologist is hard. If you don't have the opportunity in your center for ambitious trials, you're a bit stuck into the question whether or not to give temozolomide, and then you more or less envy your colleagues in the hemato-oncology. They don't know where to choose from. They have lots to choose from. And it makes you sometimes wonder, did I go for the right job? But of course we did, and I think there is lots to explore, and it's interesting to see, do we get some support from, for example, the pharma industry? And I always like to show this graph. So what you can see in the first graph is that the amount of, so you have on this side a target, and there you see the number of companies aiming for this target. So if you see the light blue one is the oncology. So in 2000, on average, say for EGFR, I just call a target, 2 companies were aiming for this particular target. But along the way, more and more people are aiming for the same target. So now it's almost 10 per individual target. And for the most popular target, so this is a bit confusing because this is the time and not oncology now, but now in 2020, for the most popular targets, more than 50 companies, maybe also startups, etc., are aiming for a particular target, meaning here CD19 and PD-L1, both immunotherapy targets. And we really should think they come to you for pediatric requirements, and should we sacrifice our patient population for checkpoint inhibitor number X just to become best in class or having a backbone? So as said, it's not a very disease that's very rare, so we should think how we efficiently learn from our patients. So we as a community should find new targets, and now with immunotherapy we have more ownership because we can produce the targets ourselves. And maybe every week you see new papers with new targets in the microenvironment for that it can be used for immunotherapy. So there's a lot going on, and therefore very promising. So I think we should move further to see if we can find targets for our population. But of course, it comes with many challenges, and I think these are, because we're an educational session, so a new generation, so a lot of things we need to address the coming years. And one of them is how to administer it. Do we do it IV, intraventricular, intratumoral? What's the best way to efficiently get the therapy there? How to overcome the tumor microenvironment? I think that's a huge issue we need to address. What is the right biomarker? Do we need lymphodepletion for CAR-Ts like for ALL, or is it not needed because there aren't any lymphocytes anyway? How to combine with other therapies, and also there's new toxicity arising. How do we manage that? How can we augment immunotherapy, because we can modify all those different compounds very efficiently, and what's a good way to modify this? And I think one which is very important, how do we strategically work together and have smart designs to really learn and not stuck into small phase 1 trials and then not moving forward. And of course, patient federations are very important as well. So just some, and I'm not going to address all of those, obviously, but I think these are important questions for the future. So I just want to touch upon 2 different modalities of immunotherapy. There are much more like checkpoint inhibition, vaccine trials, and this is obviously one of the most famous trials when it comes to immunotherapy and DMGs. GD2 is an antigen that is widely expressed on DMG cells and therefore a good target. And already some years ago, this was published in Nature that we could efficiently produce CAR that were against GD2, and the 4 patients were published and they showed some responses. So there was a lot of excitement, obviously, about this way of treatment, and we almost felt like hemato-oncologists that we could go to this direction. But along the way, we saw there were some issues also with toxicity, which was manageable, but it was severe. And we knew from the ALL world, obviously, the CRS and the ICANS, and especially the ICANS, acute neurotoxicity syndromes, we would maybe have expected in our population, but it wasn't really the case. It didn't fulfill the criteria, but we saw a kind of pseudo-progression or tumor inflammation, which causes a lot of problems. And a new kind of criteria were introduced, the TANs, that was tumor inflammation associated neurotoxicity, and that has to do with a lot of neurotoxicity up till really needing invasive surgery to manage this toxicity. And I think that's also important, that how far do we want to go to actually manage that toxicity, but in a certain way you want toxicity because you want inflammation at that point. So there's a very fine balance, how far do you go, and what is not acceptable anymore when it comes to toxicity, or for example, when you set your DLT criteria, is this allowed, yes or no? So things to discuss amongst the community. I think it's a kind of common denominator in a lot of immunotherapy trials. You see some very good responders, but that in generally is the minority. And here as well, we saw patients who had a very good response, one with complete remission, and this is still ongoing. So this is something you see in more trials with immunotherapy. So what's next for CARs? I think what I said, if you augment your CARs, so adding, for example, interleukin 7 or interleukin 18, so shaking up more the microenvironment, that your T cells your CARs are more persistent. That is something we should work on, and maybe there's more merit in it, or a CAR that not only targets the target but also off-target effect, like the CAR V3 that has a T cell engaged antibody molecule that is shed once it's attached to the EGFR, and then also goes for the wild-type EGFR, as this is overexpressed in most of the tumor cells. So this kind of way of thinking can bring us a bit further, or a recent trial that has been started in Seattle, not only aiming for one target, but for more than one target, as we know that our tumors are has a large heterogeneity. But obviously, it's very important that if we're aiming for a target, it should be there. So I think we should actively evaluate our targets. For example, B7H3 is a very popular target also for CAR-Ts, especially for embryonal tumors, but also others. And you see these are all different types of tumors, that the expression of B7H3 is very different. So before including a patient in the trial, maybe we should at least look if this antigen is actually there, and ideally see what the evolution of such an antigen is. So how does the expression, does it go up, does it go down, is it correlated with response to therapy? So this is work done by our pathologist, Mariette. Another modality of immunotherapy are the oncolytical viruses, and this is also a therapy that is emerging in the last years also for our population, and that is you inject the virus directly into the tumor cells. They selectively replicate inside those cells. Then you get apoptosis, then you get damage-associated molecular patterns, tumor-associated antigens, and due to that you get a kind of inflammation as a secondary hit. Then you get an immune response aiming for those tumor cells. One of the most studied in brain tumors is DNX2401 or delta 24-RGD, and this is modified, and one of the modification is the E1A deletion, where it that makes the virus selectively infect cells that are don't have an intact RB pathway, and that are most likely, or cancer cells don't have this intact pathway, and therefore it can only replicate in tumor cells. And this work is spearheaded for years and years by Marta Alonso, together with her team, and based on her preclinical work, and tomorrow there's a plenary, there has been a trial for diffuse midline gliomas where they did a biopsy, and then here put, after the biopsy, in a biopsy channel, put a catheter with two channels, one for the gadolinium and one for the virus. And then after the surgery, you could see, if you do an MRI without gadolinium, that is actually in a place where you want it to be. And this trial has didn't have any major safety issues, and had a median survival of 17.8 months. And also here you see some long-term survivals, like for a lot of other trials. So what's next? And I think one of the interesting things is virus maybe works a bit as a vaccine, so maybe you should boost it. So repetitive infusions is something that the field is now looking into, and recently the herpes virus G47 Delta has been approved in Japan as a treatment for recurrent high-grade gliomas, and it was based upon a trial where they gave the patients up to 6-time intratumoral infusions. So tomorrow, a keynote of Marta Alonso to tell you much more about this. So coming back to my environment, and I think what's said, environment influence what you're doing, but also you are influencing the environment, and we are not very good in influencing that. And that is also true for the microenvironment of tumor cells. There's not only tumor cells, as we all know, but a large proportion, for example, are the myeloid cells. We have a very low number of T cells, which makes it harder to come up with successful immunotherapy. And besides that there are myeloid cells, it's also important where are they. If you live near to the sea, you're more tempting to go surfing than when you have to go 1 hour further. So I think that's also how is everything related to each other. And an example of this is one of our PhD students, and I won't go in too much detail, but he made tissue microarrays and stained them with a lot of antibodies, and annotate them the microenvironment. And you see here, it's the. You see my? Oh, you don't. I'm pointing only myself. Is there a? Yeah, here. So here you see the DMGs, and here the non-midline high-grade gliomas, and you see that they annotate all different kind of myeloid cells and also some T cells, and you see that there is a difference between DMGs and non-midline high-grade gliomas, and they found a mesenchymal-like type of myeloid cells, and that were stained with SPP1 and GPNMB+, and that was almost 50% of all the myeloid cells. And that's then what's so nice, that you can look into the spatial organization of a tumor, and what you see here is that here is an area with a lot of, relatively a lot of CD8 cells. And here you see hardly any SPP1 cells, whereas you see here the staining of CD8, there are quite a lot. And the other way around, if there are hardly any CD8 cells like here, you see a lot of SPP1. So it's interesting to see, or maybe to target this, to see if this can be make your T-cell therapy more effective. So there's a continuous interaction between all the cells surrounding the tumor, but also with the tumor itself, obviously. There's more than microenvironments, also microenvironments. How does the US influence HI-Y, for example? Very briefly, you see this is a paper already quite some time ago that for a glioblastoma patient, where you see compared to control blood and patient blood, the CD4 count was much lower, even below 200, which is really, really low. And it was corrected for dexamethasone, and also for CD8 you see that this is lower, and they appear to be stuck more or less in the bone marrow, as you see in the blood. Here they are low, but in the bone marrow you see a rather high CD4 count, and for controls you don't see this. And we have looked in our population as well, and you see also here that you see quite a low amount of CD4 cells in our population, but it is not only DMGs, this is also other types of cells. Yeah, I think I skipped this one for the sake of time, although it's very interesting that you see the differences between, if you look at the bone marrow in your skull compared to the bone marrow in your crust, that's really different. And you see, for example, in the skull, you see much more clonality of your T cells against the tumor compared to what you see in your iliac crest. So just an example that is not only the tumor microenvironment, but much more out there as well. So, okay, this is because a bit of my hobby. But so just also microbiome, that is something we are studying now, and I think it's not enough to show the data, but just to show you that the microbiome can play a very important role, and I think this is a very striking study where they put patients who had melanoma on checkpoint inhibition, and the patients that were resistant, so all the patients with progressive disease, were transplanted with the microbiome of patients who were responded. And then you see all the blue lines, the patients start to respond again after the transplantation of the microbiome. And interestingly enough, you also, in the serum metabolites, you saw in those patients that the non-responders after transplantation did not show a difference, but if you see here the pre and post, there are a lot of changes in the metabolite. So I think these are interesting things to explore, and we hopefully can present our first data soon, as we also did a microbiome analysis in the PNOC 022, for example. So learn from each patient, that is very important. There are a lot of ways to sequence or look into your patients, so that is, I think, important. So touched upon some different things and challenges, and I think it's good to revisit the slides I started in the beginning. So, are we efficiently exploring targets? And I just did a quick search about the most popular targets nowadays, like the B7H3 and the GD2, and I found 126 studies and 26 studies, and they were not all DMG, obviously, but a lot were also from China, and a lot were also for DMGs. So a lot of people are studying the same compound, and those are necessarily wrong, but we should really collaborate to learn from those patients to avoid that we don't have a lot of different phase 1 trials and then cannot move further. So I think we should think of how we can manage that. One way could be that, and this is something we're working on within the ITCC, that you say, okay, we have a stage 1, so not phase 1, but stage 1 trial, where you say, oh, here we analyze a new compound, or we analyze a combination which is of interest, and based on this, you analyze it, you evaluate it the same way in terms of immune monitoring, in terms of imaging, and then you come here after you have this phase 1 together with the biology. You start thinking, okay, what would be a suitable next compound to add to this one? And then you add this one, for example, CAR-T plus oncolytic virus, and then you go to the next phase, or you say there's no compound available yet, which you would like to combine, and then you add it into stage 1. So very dynamic, maybe also very challenging, but this may be an option to move forward. So, some conclusions: immunotherapy has shown signals, but no game-changing result, but we definitely hope is arising. We should learn as much as possible from each patient. The immune system, micro but also micro, plays an important role, and collaboration is really key to move forward. And one day we'll all be like hemato-oncologists, lots to choose from. Any questions, remarks?
So, Dr. Jasper, first, thank you for a wonderful talk. It's me again, Dr. Vic from India. So, I agree completely with your approach. In other words, like, if we look at the breakthroughs in oncology, very often those haven't come logically. And I think we're stuck because we have to get grants. We have to demonstrate previous data in order to proceed in many, many areas of research. But if you look at some of the big breakthroughs, they were completely illogical, like arsenic for APL, or even ATRA for APL. That there was no background studies or molecular studies to support that. So it's like the bumblebee theory. It's not supposed to fly, but it does fly. So I completely agree with your thoughts about spreading the net a bit wider and looking at more agents, even if they may not logically seem to fit in. Thanks.
Thank you. Other questions? Move.
Jaroslav Sterba, Brno, Czech Republic. Thank you for a brilliant overview and stressing the importance of tumor microenvironment. One of quite affordable and cheap things to tackle microenvironment is metronomic chemotherapy. Any data or plans within a consortium?
Yeah, so of course the metronomic study which is most done is MEMAT as a trial, and I know this trial is expanding, and I'm not sure how much they look into the microenvironment in this study, but I think it's a great suggestion to look at it, so I will definitely bring this back to the PI of the study.
Hello, it's from the left side. So, yeah, since you mentioned about the cancer microenvironment and the immune cells, very few T cells. But in fact, both in neuroblastoma and high-grade glioma, one of the dominant cells in the cancer microenvironment is the macrophage. So, in your research work, anything try to target this, for example, M2 macrophage?
Yeah, so indeed, I think the macrophages are the most important compound of the part of the microenvironment for sure, and they play a role we don't fully understand yet. And I think the M2, M1 is also a bit like, it's not really binary. It's like it's really a continuum of different annotations that you also could see in the slide I showed you. And I think it's very important to find targets. And you have the CD47 magrolimab, for example, that has been explored, but so far it has been a bit disappointing. And it's also an antibody which doesn't cross the blood-brain barrier very well. But at least we should definitely look for things that change the macrophages in an activated state. And that can also be like maybe cytotoxic agents or HDAC inhibitors, for example. So not necessarily very targeted, but it can also, so definitely I think there is a key to make immunotherapy work to modify macrophages there. Yeah.
Regine Kipuri from Istanbul University. Thank you for all three presentations. My question or comment would be more on the clinical aspect or the clinical practice. We have to have these clinical trials to go. This is a lethal disease and we have to get better results. But when you think of the quality of life as well, having these children with something that's oral and more practical seems reasonable at least. Like we had shown in our center and published it, and also in ASCO we have presented that the children that had received chemotherapy, whatever, other than, in addition to radiotherapy, did better than radiotherapy alone in our historical data, as you have shown also already. And the ones that had received oral temozolomide did quite well in the general setting as well. Now we have another oral, the ONC201, and as far as I know, there is a clinical trial going on for adults that is randomizing temozolomide or ONC201. Do you have any results on that, or what would be your comments for the clinical practice in general if they are not in a clinical trial? Of course, we want them to be in clinical trials if there is one in your center, in your country, and wherever you are. Yeah.
I think it's a wonderful comment, and I think the quality of life is so important when we also evaluate some of these more intensive therapies, right, where children have to undergo several procedures, and we are now incorporating this, at least from the PNOC consortium, we are doing this for all of our trials, and then hopefully at one point we will be able to compare. Going back to your question with the temozolomide, I think the data is what the data is. I think there's data showing obviously negative results, and obviously there are side effects to temozolomide. The literature is a little bit here and there. In terms of the ONC201 trial, so the ACTION trial right now is really randomizing post-radiation between placebo and then two different schedules of ONC201. They are excluding children with pontine tumors, right? It's mainly for the thalamic tumors. And I have not seen any results of that. But obviously, I think one of the areas why we are so interested in ONC201, but it's a huge area of controversy, right, in terms of what other responses we're seeing. But I do think, based on the mechanistic work that also Sriram presented, it is a potential agent to build on, is how well tolerated it is. So I do think that's why I think really understanding who are the potential patients benefiting from this. And we are going back to our cohort where we now have enrolled 130 plus patients on the ONC201 pontine arm within PNOC to really understand what is it. Because there's a lot of controversy, right, about ONC201 and responders and non-responders. But I think the quality of life is a big issue, and I think also for this immunotherapy trial, and I think Jasper mentioned that as well, right? How much toxicity are we willing to tolerate in this patient population? And I think It comes back to also individual families, right? I mean, some want to move forward and be very aggressive, others don't, and they choose oral agents. So I think as a community, I think it is key to offer multiple different, therapeutic strategies so that it works that we can offer something to each family depending on their focus. But we need to learn from each trial what the quality of life impact is. Yeah, thank you for that comment. So I think with that we will end. Thank you very much for joining us this morning. I hope you will have a wonderful rest of our meeting. And if there's any additional questions, we will be around. Thank you very much.